give this webinar. Uh, I would like to share my screen with, uh, hold on for a second. Uh, Actually, I just came running from the clinic, so allow me a second and I will be with you now. Uh, okay. So I bring greetings from the Institute of Liver and Biliary Sciences. Bring greetings from a deemed to be liver university. We probably are the only liver university. And I have been given two difficult combinations. Both terms are in trouble: acute on chronic liver failure as well as NAFLD. So let's run through this session. I would like to one more time thank you. This is around 5:30 p.m. in India. I have no conflict of interest. I will briefly start with ACLF and then I will come to NAFLD. What is acute on chronic liver failure? The East and the West, whether they can ever meet. So the East, that is whole of Asia, we define acute on chronic liver failure. So the liver is the primary seat of injury. The jaundice is more than or equal to 5 milligram. Coagulopathy, the INR, is more than 1.5. After this jaundice and coagulopathy, within 4 weeks, the patient develops either ascites and or encephalopathy. The scenario is a chronic liver disease or a cirrhosis patient. So in a cirrhotic, an additional new acute hepatic insult, and they have a high mortality. So this was the first ever definition given in 2009. Now the definition given by the West is a condition which is 4 to 12 weeks. There is a gap of jaundice and or any inciting event. It could be anything, and it results in decompensation. There is, other than liver, two more mortality. It includes both compensated liver disease and decompensated liver disease. It also includes SIRS, bacterial infections, and jaundice is not necessary. So this is the main difference between the two terminologies, East and the West. What is the relevance of this? Let's say you have a patient who has a normal liver, he gets an acute insult, he will get acute liver failure. Globally, you will diagnose ALF, has HE, and has got liver failure, coagulopathy. A decompensated cirrhosis, already patient has advanced liver disease, has ascites, kidney involvement. He gets another acute insult, maybe some painkiller or maybe alcohol. He becomes further worse. Now he becomes septic, he gets bleeding, kidney injury, encephalopathy or sepsis. So these are two different categories of patients where natural history is already defined. What we are talking is a patient who has F3, F4 fibrosis. He gets an acute insult, or there is already a known patient with cirrhosis. Now, in non-cirrhotic, he gets an acute insult, can again have 5-6 variations. He can bleed, he can have encephalopathy, ascites, hepatorenal, many combinations. Or he has just one syndrome where liver failure is dominant. So where, as I showed you, jaundice followed by ascites. So in Asia, what we follow, this is APASL, ACLF Research Consortium, ARC. According to this, we only pick up one such condition. If you take the Easel or Cliff or European or American, you may have almost 27 subgroups of these patients. So you do not know, you're talking about a guy with ascites or HRS or sepsis. So is it better to have a clear definition? Yes, you have a correct phenotype. So you can give a specific treatment. Hepatitis C, treat. Cancer of this type, treat. Let us start with a patient. This is a patient we saw a few months ago, a lady obese, has started because of corona, were immune boosters in India, and she possibly, after taking 3 weeks of this, developed jaundice and she had ascites. Now, with this jaundice and ascites, she started. When she came, she had liver span was normal and his spleen was not palpable. When she came to us, it was day 23 of her taking this complementary medicine. She had no SIRS, so heart rate was okay, platelets were okay, TLC, white cells were okay, bilirubin was 22, and she already had high INR. And she already had ascites and required modest volume paracentesis, and she also had high lactate. So at presentation, she fulfilled the features of acute and chronic liver failure. Now, 4 days later, she developed full blown SIRS. She has tachycardia, although she doesn't have sepsis. Lactate is high. Now she has an organ dysfunction, almost failure. We did a transjugular which showed F3 fibrosis, and she had ascites and coarse liver. She was started on N-acetylcysteine and diuretics were stopped. She had now SIRS. Now, day 30, she was in the hospital. Now she has got full blown sepsis. She has now kidney injury. She has now high INR and high lactate. Now she needs multiple times acidic fluid. She was put on low dose of noradrenaline. Plasma exchange was given to her. Now, day 35, she has multi organ involvement, encephalopathy. She is now too sick. On day 32, according to Easel and Cliff, she agreed for transplant. But by that time, she had very high lactate, she had bad kidneys, was not a good candidate, and she died. She died on day 36 with hepatorenal syndrome, spontaneous bacterial peritonitis, encephalopathy, and all that. She also was an unfortunate case. Now, let's look at what the European canonic study data says. When they published in 2013, in their ACLF, liver failure was not at all in the picture. Only 14% had liver failure, while kidney failure or multi-organ failures were common. So liver is there, but also kidney is gone, circulation is gone, as in our patient. So we diagnose this patient much later, like the canonic study. So this definition of ACLF by East and West were compared in a very large study of 80,000 patients of cirrhosis in the American cohort. David Kaplan, Nadeem, they did this. And what they showed was there is significant discordance in ACLF as diagnosed by Easel and Apasal criteria. Why? Their mean bilirubin by Easel was only 2. Now, with a bilirubin of 2, which is common in cirrhotic, and you diagnose as a liver failure, acute or chronic, but there is no increase in bilirubin. So, their conclusion was that we should suggest the need for more liver specific ACLF criteria. So, this is to summarize how the two definitions diagnose acute or chronic liver failure. So, there is an acute insult, let's say, in our patient, this was immune boosters. Now, she developed jaundice. It was for about 7-8 days. Then, after her liver failure, other organs, kidney or brain or lungs, they started failing. So there is a gap of about 6 to 10 days. So what is the difference primarily? First, it accepts pure liver failure. It does not accept just extrahepatic organ failure. Third, it allows you time to prepare for some treatment. So the choices are clear. A more liver specific definition would not only preserve the syndrome's face validity, that is liver failure, but would also be more useful clinical tool in selecting patients for liver directed therapy. Let's say you start defining ACLF based on organ failure, whether kidney is gone, whether there is a circulatory failure or encephalopathy. It may be a bit late, and the potential of reversibility is gone. Organ failure should be part of natural history rather than essential that everyone must have this, then only I diagnose. In acute liver failure, organ failure, sepsis are not part of definition but only for severity score. So let's summarize this part. Define a pure phenotype. Liver is core to acute on chronic liver failure. Organ failure are not needed for definition. Decompensated cirrhosis has a separate natural history. They have multiple outcomes. And sepsis is a consequence, not a cause of liver failure. We saw patient had initially high bilirubin but no SIRS, then developed SIRS, then sepsis. So let's focus on severity. Organ failure is still not there. Index organ failure is liver. So what are the four dominant manifestations? Jaundice, coagulation disorder, encephalopathy, and lactate. They form the liver failure part. Like in ALF, and creatinine is the kidney where it is secondarily involved. So ARC ACLF score, APSL ACLF Research Consortium score. Let me show you. Our patient, when the patient was admitted, this lady had bilirubin of 22.5, no He, had high INR, lactate was 2 point something, and creatinine was also high. Her ARC score was 10. Now, 4 days, and she fell into a category of 2, category 2 of grade 2 liver failure. Now, after 4 days, she now had higher INR, higher lactate, and higher creatinine. Her score became 13. Now, 13 score means she is in grade 3 ACLF, grade 3 liver failure. So, this for the first time tells you in 7 days' time how our patient, sorry, this patient 4 days' time, how the patient has behaved. What is the relevance? If grade 10, then 1 unit increase by day 4 will be 4% increase in mortality. And by day 7, 5% increase in mortality. Our patient came with 10. Now, with a 10, 1 unit increase above 10, our patient went to 13, has an increase in mortality by 20%. And therefore, by 7 or 8 days, this patient died. 14 days, the patient died. So this is to show you that ARC score, that is the Asian score, compared to Cliff SOFA score, this is the ARC score, thick line. It is far superior in the ORAC as compared to any other score. So this is a very good indicator of severity of ACLF in a cirrhotic population. And what is the golden window? What we learned in that patient from day 23 to day 30 was a period of 7 days. This patient had no SIRS, but then she patient developed sepsis from SIRS, and from SIRS, one also organ failure could develop. So we only had a 7 days period. And it is in this that halting inflammation, sepsis, organ failure, we can reverse the process. How do we diagnose ACLF? We diagnose ACLF by giving this kind of a simple history. Patient has acute insult, uh, chronic insult. So let's say acute was immune boosted, chronic underlying NASH, she was obese. So bilirubin, INR will give you liver failure. Ultrasound, CT will tell you chronic liver disease. Ascites will tell you acute portal hypertension. Patient had no varices, so we had to go for transjugular. If patient has varices, then you don't need anything. And a pressure above 10 millimeter tells you it's underlying chronic liver disease. So what is ACLF? A patient who presents with acute hepatic insult or liver failure but has underlying bad soil, has chronic liver disease, and there is an acute insult. It could be ethanol, hepatitis B, viral hep, or daily drug induced, like our patient. Then underlying chronic liver disease. Our patient had F3 fibrosis, not really cirrhosis, and the liver failure, which we defined. So, acute chronic liver failure. But why do we do all this? Because there is a potential of reversibility in these patients. So you do a liver biopsy. What does liver biopsy tell you? Oh, there is cholestasis. All the bile plugs are there everywhere. And there is eosinophilic degeneration. This patient, not the one I showed you, if there is such a patient, the patient will die. Ballooning degeneration, on the other hand, as you see, may be benefit. So this classification we gave about 10 years ago, that if somebody has stage 3 fibrosis or patient has ductular proliferation or cholestasis, a poor outcome will occur. Ballooning may help such a patient. It shows regenerative activity. Now we are using second harmonic generation SHG, where we just not only do the portal area, but we also do the between the portal area, the complete fibrous tissue laying down in the. So we find out about the thickness of the fibril, the length of the fibril, all that. So it gives you the collagen proportionate area as well as the type of collagen. And this is just to show you this correlates very well with hepatic vein pressure gradient. This paper recently published. An important aspect is albumin in acute on chronic liver failure. You all know albumin is the most widely made protein by the hepatocyte. It is the most important part of the plasma protein. I want you to show this interesting area like acute insult, alcohol, pills, or virus, whatever. What happens in acute and chronic liver failure are these two important things. There is a albumin which is modified. It is structurally different, and there is more of nitrosoalbumin, more of albumin which is non mercaptan albumin. Normally it is a mercaptan albumin. So non mercaptan albumin type 1 and type 2. These are totally oxidized albumins, and they are no good for anyone. They are actually very toxic. So what happens? You have a modified toxic albumin. And in an ACLF patient, if you keep giving albumin and albumin, like you have seen recently the entire trial in New England, even for decompensated, there is not much benefit shown. In these patients, there is a better idea of removing this albumin rather than replacing the albumin. Now, why is this important? Normally, one molecule of human serum albumin binds to one molecule of bilirubin. But if the bilirubin level is, let's say, 15, 20, like in our patient, then one molecule of albumin will bind three molecules of bilirubin. This is hyperbilirubination of the albumin. Now, nothing else can bind. All your good areas have been taken up. So, bilirubin binding sites have taken metal binding sites, they are drug binding sites, everything is gone. So, such an albumin is no good, should be removed. And therefore, we have to think whether liver dialysis or similar such things must be combined. So let me summarize this part. We diagnose acute and chronic liver failure by history, acute and chronic, and some diagnostic tests biopsy for etiology if not clear, endoscopy to see underlying portal hypertension, and HVPG for portal hypertension. Albumin biology functionality must be studied. It's a huge interest. Whether the albumin is toxic, then replace it. And I showed you the simple ARC score, no complicated gadgets needed. Bedside, it's good, reliable, tells you the prognosis, stratifies for transplant. And golden window of 7 days must be remembered. Now, briefly, one or two slides about mechanism and then NAFLD. Now, in the gut, there are large number of bacteria which are commensals. But once somebody has taken alcohol or has an acute injury due to, let's say, viruses, others, then there is a leaky gut. So this leaky gut permits the bacteria, especially the non-commensal pathogenic bacteria, come through the portal vein. The inducer of the injury is the acute insult by alcohol, virus, whatever. So there is cell death, DAMPs are released. These DAMPs plus these bacterial endotoxins, they stimulate all kinds of immune cells in the liver. And there is an inflammation, there is cell death, which is perpetual. It goes on. And I can't go into details, but just to tell you that the inflammatory cytokine milieu, just like cytokine burst, all these cytokines are increased, they go into systemic circulation, and the cycle continue. So the injury, sorry, is sensed, the mediators sometimes overshoot. Finally, this might lead to an organ failure, as we saw in our patient. So, the pathogenesis is cell death multiplied by the dysbiotic leaky gut. A very important part of this ACLF, I hope I can explain you, is an acute portal hypertension. Now, in a cirrhosis patient, you already have a very high level of portal pressure. And this portal pressure is now further increased due to high bilirubin and bile acids. And high bilirubin and bile acids are major cause for increase in cytokines, activation of stellate cells, endothelial dysfunction, impaired vascular relaxation. Let's see, a cirrhotic patient already has raised portal pressure. With this, what happens? Bilirubin will cause a cholecardia. Cause kidneys to become cholemic nephropathy. Kidneys tubules are blocked. Bile acids are high, depression of the cardiac functions. Cytokines, I already told you. Stellate cells will cause huge, increase in the pressure. They are the gatekeepers of blood flow. So the levels go up. Endothelium is damaged and it doesn't relax. So acute rise in pressure, let's say from 10, 18 millimeters. And what it results into is an acute development of ascites, sudden ascites. Kidneys are not getting the blood, patient may bleed and go into encephalopathy. With this in mind, how does NAFLD come into it, and what is the different part of NAFLD, what we are discussing? So I have covered with you the terminology, covered with you the mechanisms, and acute portal hypertension as a syndrome. Let's look at NAFLD. In a recent publication, we showed that in Asia, the is somewhere around 10 to 20% in different countries. This is same for NASH cirrhosis globally. So this is NASH related cirrhosis. This maroon kind of thing, brownish maroon, is different countries from 9% to maybe 20-25% or so globally. Now, what are the proportion of causes for deaths due to cirrhosis in 2017. I have picked up Italy. I hope it interests you. That in several countries, high income North America or others, NASH is about 10%, alcohol is 28%. I think Italians are very, very civilized and they don't indulge that much in alcohol like others. And even NASH, they are very exercise friendly. They like nature. So there is only 6% of NASH in that population, as reported. It may be higher, but as reported is 6%. Well, the number of prevalence in Italy, I have found this. The increase globally, when you look at from before to now, between 90 to 2017, what has increased globally? NASH has increased 55%. In high income countries, 33%. Italy also 30%. So maybe earlier NASH was not so common, or maybe was missed by some reasons or so. Now, acute on chronic liver failure in NAFLD. So I have told you what is ACLF, NAFLD, and the causes of NAFLD for cirrhosis related deaths. Now, if you look at it, HBV is where 16% and 15%, this is still Asia. So, hepatitis B is a common cause. I don't want to stress that Asia has been spoiled, that alcohol makes 50% or more. NASH, same like Italians. I think it is more underreported, but as reported, 6%. Painfully, alcohol has become number one. Let's look at other CLIF, which is a different way of diagnosing. Even in CLIF, about 5% or so. Canonic was 18%, but when they validated, huge difference. So let's look at the way, this is in liver transplant, a paper. It shows acute on chronic liver failure is more increased by 24%. But NASH, when you compare to others, alcohol was there earlier, virus was there earlier. But now NASH, amongst those where the numbers have increased, even from 3.5 to 5.7, it's a statistical gimmick. But 63% increase is shown for NASH. So it may be one of the more important, rapidly rising things. Now, when you compare this ACLF, there are so many slides and data I have just removed. NASH ACLF versus other etiologies, B, C, and others. More males, more Caucasian. This is the data from the US. More comorbidities, longer stay in hospitals, more expensive, maybe a few days extra, more need of dialysis because, as you know, diabetics, hypertensive, they generally have some CKD and they need long term care. And the cost of care is also high. So we need to remember first, even small increase in the number burden on your economies. We need to be careful that we should not let them go and develop acute and chronic liver failure. This is another large database from UNOS, the American Registry for Transplant, of 100,000 patients who were on wait list, liver transplant wait list. 15% were NASH. Now, if you are 15% are requiring transplant, it's a huge number. And when you look at ACLF, there is a 24% increase in them. They diagnose differently, kidney involvement, sepsis, but whatever is the reason, NASH is important. You can't ignore it. And what is important is renal failure. So what is the problem? The problem is these guys may require double transplant, simultaneous liver and kidney transplant, which is not easy. So the demand on organs by NASH people might actually increase. Furthermore, infections are the major cause. So they will need all kinds of drugs, including all expensive antibiotics. Does that mean every patient who is obese, every patient who is NAFLD is bad? No. See, Mona Lisa, somebody looks at from a different point of view. Similarly, every lean person is not healthy. He may be normal weight, metabolically unhealthy person. So I want to stress upon it that ACLF also can develop in lean people, but they have genetic traits, metabolic traits, and that can create a problem for them. Now, when you look at it, the incidence and mortality, when you use the definition, as I said, by Cliff SOFA or by Apazal and ARC score, you see the difference in mortality. And I will show you in overall, NAFLD compared to others did not pose an extra burden on death. However, 90-day mortality was amongst the highest in the NASH group. So NAFLD does not make an extra. In fact, the incidence of ACLF may be lower compared to alcohol. Alcohol may have the highest. I mean, the guy keeps on drinking, it doesn't stop despite jaundice. What can you do? So he has a higher chance of risk of developing liver failure. However, mortality in this group is higher both because of kidney and infections. Now, this is just to show you that NAFLD, but a puzzle comes like here, and with easel, it comes like in the lower part. So when you see the incidence, it is lower with this compared to a puzzle. Now, the survival. The survival in the group of NAFLD, according to uh, uh, a parcel in NAFLD group, as you can see very carefully, is not too bad, is worse, and compared to any other etiology, and NAFLD even by EASL, but EASL does not give that good a picture as a puzzle, which gives you clearly higher mortality. Now, this study published last year is an interesting. This is a huge data from ARC. Canonic was 1400. This is 2000 patients who had been enrolled in the ARC database, of which metabolic risk factors seen in 33%, 407 of the selected, not have any metabolic risk factors. And the risk factors included overweight, obesity, diabetes, hypertension, dyslipidemia. And the severities and the outcomes were assessed. The 30-day mortality in these patients who had no risk factors versus those who had risk factors, only overweight, obesity was the worst outcome, and that too only on 30-day. Others did not. When you look at 90-day, there was no major difference in any of this. So what I want to say that ACLF develops, ACLF can create more problems. The incidence is not that high, so don't get panicked. But mortality can be high, especially 30-day. So what we need to do, if you have a guy who has and develops ACLF, decide in first 7 days whether you want to do transplant or not. Otherwise, kidney and others can create more problems. This is one of our very interesting study. Now, if a patient comes with ACLF, or let's say cirrhosis even, and this patient has NASH. Now you ask, this guy is sick, he's intubated, you can't find out. You ask from the relative, well, father, mother, anybody had metabolic history? Whether somebody else in the family had diabetes, and then you will immediately know this patient. So what we did in a large series of about 1000 plus 1100 patients, that those who came, about half of them or even more had either themselves suffered or had a metabolic trait. So metabolic traits are common, they cannot be ignored, and they can create sometimes more problem in first 30 days of life. Now, what happens with COVID? Everyone is talking of COVID. The studies show, and all over the world, comorbidities included age, elderly people, those who have high BMI, or other diabetes and cardiovascular. But when they see the NAFLD study, large study, NAFLD per se, just alone, fatty liver alone was as high a risk. The odds ratio of a severe progressive COVID were same as if any other comorbidity. What it shows that liver is at the core of all other metabolic derangements. NAFLD cannot be ignored, whatever kind of severe illness comes. Now, last part would be about new treatment options in acute and chronic liver failure. I'm trying to give you overall picture of managing acute and chronic liver failure. The patient has to go to the ICU. He's a sick guy. He has high MELD, has high ARC score. What do we do? A patient has a bilirubin of 20, he's not feeling like eating. Can you give fat to a person who is sick? Yes. This is what we showed 2 years ago in ASLD and published last year. Giving omega 3 is like an anti inflammatory. In fact, it improves survival at 30 days and even at 60 days, not 90. So, omega 3 can be given firstly intravenously, and it is an anti-inflammatory, brings down TNF and others. Now, a patient has a flare, acute on chronic liver failure with deep jaundice, either due to alcohol, he will get steroids if he fits in. The discriminant function is above 32 but below 90. Or in hepatitis B flare, I just saw a doctor just in the clinic 2 hours ago. He was on drugs, and this guy, very interestingly, he got COVID last year, early this year, and he stopped taking tenofovir. He thought, well, I'm okay, forget it. And today he comes with a bilirubin of 10.7 with high INR, tachycardia, he's in liver failure. So this is not advisable, you continue. And autoimmune patients certainly need to continue with the steroids. And up to a 27 MELD, you can give steroids in ACLF autoimmune. Above that, straight transplant. Now, as I showed you, a patient who may have a portal pressure of 8 or 10 or 12 or 14 suddenly increases 1.5 to 2 times. So this sudden rise, varices, collaterals are not able to digest, they will bleed. So we showed last year, 2 years ago, this was a plenary at ASLD, that if you start carvedilol or beta blockers early enough in these patients, don't let the pressure go up. You can prevent bleeding. Of course, you can do band ligation, but patient will bleed coagulopathy. And a preemptive tips, suppose the patient you have banded, he bleeds, you can do a preemptive tips in these patients. Now, very interesting concept. We have a concept of large volume paracentesis, LVP, that is more than 5 liters. The gut guidelines 2021 give albumin only if it is more than 5 liters. But in a patient with ACLF, the way we describe, the way we understand, first time he has got ascites in a small abdomen. The muscles are not relaxed. So there is a huge intra-abdominal pressure. Now you do paracentesis of 5 liters, he gets into paracentesis induced circulatory dysfunction in no time. So we suggested and brought this term modest volume paracentesis last year. I have don't showing you different slides. Now, even if you tap 4 liters MVP in ACLF, the patient gets PICD in 70%. 70%. Then you give albumin. This was a randomized trial in hepatology. Albumin given, you decrease from 70% to 30%. What I want to tell you, acute portal hypertension decompress slowly. And plasma renin activity of 23, 25 is a cutoff. This patient will have PICD. Normal plasma renin is less than 4. The next problem is liver failure. These patients have coagulopathy. They have very high lactate. So you give based on ROTEM, whether you want to give fibrinogen or you want to give platelets, just based on ROTEM correct. Comorbidities, NAFLD have all challenges of continuous liver failure. What do you do for liver failure, for encephalopathy, and for kidney injury? Let's look at it. So we need bridging therapies, plasmapheresis. We need something like liver dialysis, Mars or Prometheus. They can be a bridge to liver transplant or a bridge to liver regeneration. There is a possibility you remove toxins, whether the liver can regenerate. So, what is the rationale of plasma exchange in ACLF? It can detoxify, it can allow regeneration, and it can cause homeostasis. So, this is the fundamental. Now, our first line treatment has become plasma exchange. This is not to, like kind of some patients may come out totally, but the final thing is it is a bridge and allows, stimulates regeneration. This is to show you just one slide. This is plasma exchange, and this is Mars or Prometheus. There is an improved. So this cheap, simple, available technology can improve survival benefits in patients compared to. So this is 28-day mortality. The hazard ratios for this are lower and patients can improve. This is a very interesting slide. I want to spend half a minute on this. So you do plasma exchange, in 6 hours, can you tell this patient will survive or not? So we do monocyte oxygen consumption. This is the oxygen consumption rate using seahorse. Now here is a red one is a non-responder, and the blue one is also a non. These are two patients. And here is a responder, one patient. Now what does it mean? When you have done plasma exchange, within 50 minutes to 100 minutes, the monocyte is now going to mitochondrial respiration. So this is a recovery. Mitochondria are now functional. In these two patients, mitochondria were not functional. And this is a now simple bedside. Patient comes, we send it for the OCR. OCR is this. No, 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 this patient may not survive too long. Maybe we do one more plasma exchange, but plan transplant. And this you can do in 1 hour. Now, patient has got kidney injury. Kidney injury is more common. Acute kidney injury, it is more severe. So, what is the algorithm? Patient comes, you can give some volume, crystalloid, then colloid. If the patient makes urine, it is good. The chances are very low, maybe 20 to 30%. Rest of them, you will have to put them onto vasoconstrictors like terlipressin. The response with terlipressin is only 35%. So overall, maybe 40% to 50% will get better. Half of your patients with high bilirubin, with liver failure and cirrhosis will not respond. So be ready that they may require an early CRRT or SLED or even early combined transplants. Infections. Hepatic injury causes intense inflammation. It is the driver, as I showed you, that leads to further SIRS and that leads to sepsis. And there is an impaired neutrophil, monocyte, T cell, and DC response. I don't have time to show you except this old slide. A cirrhotic alcohol or virus gets ACLF. Neutrophil dysfunction, we showed in several studies that now neutrophils are not functional after 18 hours or so. So that leads to sepsis. Sepsis leads to all other complications. But can you change it by giving granulocyte colony stimulating factor? You can make neutrophils more functional and also dendritic cell function. You decrease the gamma interferon produced inside the liver by giving GCSF and improve the DC function, and this prevents sepsis and organ failure. GCSF, in addition, can also mobilize CD34 cells from bone marrow. And this is shown that at baseline, 30% CD34 containing area, and while after GCSF, up to 70% of the area has the CD34 positive cells. And this led to an improved survival compared to no GCSF. I must emphasize very carefully selected patients because in advanced decompensated cirrhosis, as one of the European trials showed, there is nothing in the bone marrow. It is exhausted. It is finished. You need a marrow which is good and can send some good regenerative cells. Our last part is liver transplant, where which can give you 85 to 90% survival. Now, this slide was a survey of 84 liver centers in Asia and all over the world. The reason patients were not transplanted were they came with sepsis or two more than two organ failure. This is if you diagnose them by Cliff or EASL definition. So my point of view is if you diagnose early, you will be able to transplant. Now is some data on NASH and ACLF. Now this is just to show you number of ACLF patients listed for liver transplant. Now this is the NAFLD, this is alcohol. It's still number one, but the numbers are increasing, while for Hep C and others are decreasing. Here you can also see that wait list registration for NASH is also increasing. Alcohol, of course, maximum. Now, this is also to show you there is an increased 162% increase in the wait list and the need for transplant, and this is because of NASH. NASH and ALD, in fact, are running neck to neck to the total number of liver transplants being done. Now, in the patients with NASH, we know that liver cancers become common. So today, NASH and HCC developing in NASH, in fact, is the most galloping, most fastest growing cause of liver cancer. You can see that NASH and HCC. So NASH, ACLF, NASH, HCC demand liver transplant. Outcomes. Well, here you can see that the outcomes over the years, you can see that percentage annual liver transplants here. As you can see, it has increased for ALD, it has increased for NASH here, you can see that, and the survivals. Have we made a distinct difference in survival? Survival at the end of 10 years with NASH is just about 50%. It is probably the lowest compared to others. Non-NASH, but non-NASH generally up to 10 years or 8 years, so 10 years would be about 60 to 70%. While NASH, there is a recurrence of NASH in the new liver. Here, if you do an ACLF in NAFLD patients, here you can see NAFLD, ALD, and HCV. Now, ALD, ACLF, the 1 year post-transplant survival is better than the one with NASH. So NASH, in 12 months' time, the survival comes down, unlike ALD or so. So what I want to say is that post-transplant, NASH remains a challenge. Pre-transplant a challenge, post-transplant a challenge. This is to just show you my summary slide. NAFLD and ACLF is a challenge because such patients have more progressive disease. They require renal support. Survival may be poor, and you have to make an early decision because 28-day, 30-day mortality is bad. So let's say a patient comes to you of any ACLF, including NAFLD. On day 0, I will assess whether sepsis has occurred because sometimes to referral centers, patients come late. So organ failure also has to be seen. Now, MELD is above 30 or ARC score is above 10. I showed you above 10. Every one increase is 20% increase in 7 days mortality. So such a patient has come to you, straight away transplant. Don't wait, just stabilize this. However, while you are preparing, and generally we'd have living donor programs, by day 4 or 7, his ARC score has improved from about 10, it has come to, let's say, 9, 8, or 7. Then you can plan medical therapy. Suppose it's not improving, increasing, you need to send for emergency transplant. From, let's say, MEL 30, 32, it has gone to 40, or ARC score is 13, like our patient, transplant in a week's time. If a patient like Is Aclf has come with an organ failure of more than 2, What you can do, you can't get an organ that fast, at least in our parts of the world. So we put them onto plasmapheresis or artificial liver support by Mars or Prometheus, try to stabilize them and improve. If they improve, if they improve or become stable, emergency transplant. Earlier they could not, but now emergency transplant. If they're not improving, you tell the patients futility, just supportive care. However, if the patient has come from beginning with a organ failure of 3 or 4, this patient, no point. So using Is Aclf, you will be in this part. Using Apostle, you may be in this part and may be able to help more patients to go for transplant. All these are published in Hepatology International. I encourage you to try and improve the journal by your valuable contributions and also to join ARC. But we have miles to go in ACLF and NAFLD. First, of course, we need a good, combined, understandable, universal definition. We also need to pick up patients with organ dysfunction, creatinine of 1.1, not 1.6. Every organ must not fail before recognizing. We must have focused therapies. Liver regeneration must be given a huge impetus. The liver regeneration during liver failure is our total interest now for last about 5 6 years. So how can you regenerate liver during liver failure? Of course, we need new devices for liver support, remove toxins, make the albumin better, renal support, and high priority are transplant teams and the availability of a living or deceased donor within first week of transplant. We have miles to go, and therefore we need you to join us. We have now in the ARC about 7,000 cases plus, I think, 7,200. Please join us. Please make this a combined effort for improving patient outcome. With this, thank you for allowing me to present my thoughts, and I'll stop sharing and be with you.
Well, thank you very much. I mean, it was very impressive presentation. A lot of data, very solid and good clinical work with a lot of hints. Now I open the discussion before making my own comments and questions. Is anyone wishing to comment? Waiting for, I'll break the ice. I mean, I'm very much impressed about the story of albumin and the rearrangement of albumin structure and binding properties. This recalls me something we see in the newborns, and I'm sure that someone looking at this webinar is very familiar with John Batchko and Terry Hintz. In the newborns, you are using the ratio between albumin and bilirubin, unconjugated bilirubin, to predict neurological damage. Did you ever check this ratio in your series? Because this could be very interesting to see whether this ratio, which is very easy to perform, it's just the ratio between albumin and unconjugated bilirubin, may be predictive or more severe damage or death. That's my question.
You're absolutely on the dot. Patients who are unlikely to survive, gradually their indirect bilirubin is rising. Compared to them, they have something like an HLH, and hemophagocytic lymphocytic syndrome, and they have very high levels of ferritin, sometimes as high as 15,000 or so, and they have like sometimes autoimmune anemia kind of a feature. These patients are bad. The another interesting part, and which you can test, and we published last year, that albumin is optically invisible. But once it binds to bilirubin, it becomes visible.
Yeah.
And from a circular, it becomes a elliptical thing. And the ellipticity of the albumin can be tested on a simple spectrophotometer. So more elliptical, more than 1.45 is the ellipticity ratio, then these patients do not survive. So what you are saying about newborn and others, I have no idea, But certainly there is a lot to learn in albumin, and I will now look into the ratios more carefully.
Well, I will be interested to know. Any other question, comment?
I have a question, so if it's all right.
Jerry.
This is Terry Hines. It was a really nice talk. It was very enlightening. Thank you so much for that.
Thank you.
So, I have a question. So it's about bilirubin, and it's you kind of made it clear to me this is kind of a double-edged sword. So my work, and then Dave Steck's work together has shown that bilirubin prevents NAFLD, and it has a beneficial effect when you have fat in the liver. But with your really nice presentation, it got me thinking that in cirrhosis there might be a switch that happens, that when you have very high bilirubin levels, that something else is happening, and it might be wiping out the immune system to cause sepsis. What's your thoughts on that? I don't have any scientific proof or anything. I'm just a kind of a thought process I was thinking about as you're presenting.
Well, Terry, this is half an hour discussion just on this point. I will start off with the monoconjugated, diconjugated, or unconjugated bilirubin and the ratios. Nobody has studied. Kindly help us. There was a beautiful study in Scandinavian Journal of Gastroenterology several years ago that a higher indirect bilirubin is protective because it is an antioxidant. It prevents from coronary artery disease. It prevents from NASH. However, and it was shown that this is up to a level of indirect bilirubin of 2.5. If it goes above 2.5, then it may not be, I don't know much, you may know it, it may not be beneficial. That indirect bilirubin may be, So then after that, I read a lot about the mono and unconjugated. So the proportion of mono to unconjugated also makes a huge change. So coming back to your question, is bilirubin protective? Well, the direct bilirubin of that level is not. It is highly toxic. It causes cholemic nephropathy. I'll give you a just simple example. We have a lady, she took another immune booster like the patient I presented. She is admitted right now. Her bilirubin was 31. We did plasma exchange, it came to 22. Her creatinine was 2.4. Second plasma exchange, her bilirubin is now 16. It is half from 31 to 16. Her creatinine has come back to normal. We have not given diuretics, and she is now creatinine of 1.6 or so, and her kidneys have started pumping. What I want to say is that cholemic nephropathy, then we published the same in Hepatology about 2 years ago. We did biopsies of all those patients who died with ACLF. Now, in that, there were bilirubin casts in the kidney. Presence of bilirubin cast in the kidney led to development of chronic kidney disease in them in 1 month time. So one thing I am clear, that direct bilirubin causes kidney injury. Direct bilirubin is harmful for kidney, and indirect, whether it is beneficial to what level, I don't know.
Thank you.
Maybe you can do all bilirubin work for us.
We are, yeah. Actually, that's funny you said that. We have projects going on right now. Actually, we just got some really interesting data, and Dr. Shoes
we can have some project with
us too. Yeah.
Okay. Any other comment, question?
Yes. Amazing presentation, Professor Sarin. I would like to have a comment on the role of drug-induced liver disease in promoting ICLF.
Yes, there are 2 publications. One is on American Journal of Gastroenterology 2019 from the ARC ACLF, and one just published about a month ago, the consensus statement from Asia, a Delhi consensus statement on ACLF. in Hepatology International. Now, having said that, we have learned that the immune boosters or the plant related or other drug related is an entirely different kind of ACLF. Every patient has autoimmune markers positive. ANA positive, asthma positive, LKM positive. They have high IgG. You do a biopsy, and even the pathologist says there are some plasma cells and something. Now the question is, and people are saying that is it the autoimmune phone hata de. Is it autoimmune liver disease? They want us to give steroids, and we have not. We have not given steroids. Very interestingly, after few months, at least I have seen few patients, the autoimmune markers become normal. So the unique part is the drug-induced injury causes most often an acute autoimmune presentation. We do not know how to treat. There was one paper in hepatology about 2 years ago. If there is a duct, January 19 or so, if there is a duct loss of more than 50%, give steroids because 80% will die. So we started giving steroids to few patients who on drug induced had more than 50% bile duct injury. No benefit. No benefit. What we did was we did first time transjugular, bile duct damage more than 50%. We repeated a biopsy after 2 months or so, 100% bile ducts damaged. It was like a vanishing, vanishing bile duct syndrome. I do not know how to treat them, and everybody doesn't get. So maybe you can guide us how you manage it.
Okay, thank you.
I use the same. We don't use steroids.
Okay.
Thank you, Lori. Any other question? Well, if not, let me thank you again for this wonderful presentation. Very, very important in the clinical and in the basic science. And thank you very much again for your time, if your wisdom to share with us. Thank you very much. If you don't mind, okay. Okay.